You know, our last speaker, before we really have a conversation about where we go from here, is somebody that I am really very excited to hear from today, is Clarence Jordan. Just a little bit about Clarence. He is the Vice President of Wellness and Recovery for Value Options Behavioral Health Services. He directs the company's national recovery and wellness efforts. He's also a former board member of the National Alliance on Mental Illness, and has received a whole number of awards for his work around consumer leadership and advocacy. You know, one thing, and I don't really understand this, Clarence, this is not on your bio, but he and I worked together 15 years ago in a very small organization in Nashville, Tennessee, and it's so great for our paths to cross again. I'm so, you know, I just so admire what you've done, you know, in terms of your national advocacy and leadership, and really grateful for you coming to share with us today. So,
thanks, Al.
Welcome.
Good afternoon. It is afternoon, and it's after lunch. So I'm going to change my format a little bit. I need the clicker thing. Am I too loud? No, is that it? Okay. I want to begin by asking you a question. Who among us have ever experienced a traumatic event in our life? Loss of a child, a messy divorce, repossession of home, firing from your favorite job? Second question, how did that make you feel? Just shout it out. Huh? Bad? How did it make you feel? Overwhelmed? Hopeless? What was it? Dead? Scared? Anything else? Hopeless? Lost? Anger, anybody? Been there, done that. I want to talk a little while this afternoon about something, I mean, we're all in the mental health field, and I think the topic that has not been discussed is how that impacts on the individual from their perspective. And you just said it. You just said it. Receiving my first mental health diagnosis left me feeling all those things. Tom's absolutely right. This is not my chosen profession, per se. I kind of backed into it. My real job in life was a naval aviator. 15 years in the world's finest Navy, where I secured a master's degree, business administration, 2 years of law school, International School of Law, Washington, D.C., right here. And it was upon leaving the service that I began to notice that things were somehow different about my world. There were things that I began to lose control over. There were things that caused me to have complex emotions. I bummed around from town to town, from job to job, for over a decade. Then as things worsened, my situation got more and more desperate. Homeless. The only support I received was from family. Scared, you bet. In trouble with the law. Vagrancy, trespassing. The kinds of things that we typically see. Numerous parole violations. It's said by William White, in a world of aberrant behavior, there are no bizarre behaviors, only degrees of insanity from which we're all trying to escape. And in fact, that was my life. Surrounded by multiple sessions and bouts of insanity. Title of this, Indispensable Role of Peer Support in a Journey to Well-Being. This is exactly what many people with mental illness experience on a day-to-day, ongoing basis. How do I know? Because I've been there, done that. The most challenging for me was the impact that it had on my identity. naval aviator, 15 years in the world's finest Navy, war hero, decorated, 2 master's degrees, International School of Law, and I'm homeless. My life has become a mess. In effect, a real mess. M-E-S-S. Misery and evil side by side. Hopelessness and social isolation. The concept of peer support is not a new one for us. It's been around for many, many, many years. From the rooms of Alcoholics Anonymous, we learn that one alcoholic helping another is without parallel. It's not only in behavioral health, it's also in physical health. For some time now, survivors of breast cancer in the medical community have been working with individuals who've just recently received that diagnosis to help them navigate the experience of what it means to receive such a diagnosis. Here's what we know about it. And we've been talking this morning about a lot of things that you're going to find repeated in this presentation. I want to share with you some things that individuals who receive peer services have said. So this is member or consumer reported data. Satisfaction almost universal. Everybody is happier that they receive these services than not. Decreased symptoms, increased coping skills, and awareness of early warning signs. Fewer hospitalizations, shorter lengths of stay, improved social functioning. Let me back this up with some stuff that many of you are already familiar with. Claims data. Anybody? Claims data? I became interested in one particular individual back at my agency in Memphis. This individual, in terms of claims data, for 12 months prior to receiving peer services, had 147 days of claims data. 147 days of claims data. Post-receiving peer services for a similar 12-month period of time, 47. 47. That's not universal across all peer-related services, but I think what's most interesting is the pattern of usage. Hospitalization, in majority of instances, have all decreased after having received peer services. Individuals who are receiving treatment for substance abuse, almost universally across the board, decreased. Claims data. Who becomes a peer specialist? Interesting question. A good question. I'm glad you asked. Who becomes a peer specialist? Well, as Tom pointed out, I did 15 years ago. 15 years ago. And I'll tell you why. After coming out of treatment, and that's exactly where I found myself. This is my first job after coming out of treatment. Individual named Michael Cartwright, some of you know the name, interviewed me and hired me on the spot. He said, Clarence, let me show you where you're going to work. He took me down to the library/resource center and said, this is your world. Have at it. Well, it wasn't too attractive in my opinion. So I started gathering up some furniture and some chairs and threw some rugs on the floor, mood lighting, got some brochures and pamphlets from 12-step meetings around town, brought that in there because I knew that people would need that. I did. And so I'm sitting there one day, approximately 2 weeks after being in the job. Michael comes in, he says, Clarence, what are you doing? I said, Michael, I'm working. He says, no, you're not. I said, Michael, yes, I am. I'm working. He says, no, you're not. And immediately I thought, okay, I'm delusional again. I'm really not at work. Then where am I? He says, come here, let me show you something. So he took me over to the racks. Again, this is a lending library bookstore. And he's pulling out books by Scott Miller, Bob Drake, Kim Muser. He says, what did this author say about this condition? What did this author say about, I said, whoa, slow down, Mike. I've been in job 2 weeks, man. He says, no. He said, I don't want you to come to work because it's your job. I want you in the resource center for 2 reasons. You have a story to tell, and you have the ability to reach people. Now you need to become a subject matter expert. And to help you with that, I want you to take a book, any of these authors I just mentioned, and read it. And every week we'll go to lunch. And you can tell me about the theory. You can tell me about the author. You can tell me about their conclusions. My life changed that day because, indeed, I had come to work for a job. And something changed. Michael has a book, Meaningful Hope. I hope you read it. It's beyond recovery. It's about what's your purpose in life? What do you want to do? Who are you? We began with people with lived experience, a strong personal sense of maturity. More importantly, it's the training we provide individuals. Someone mentioned protocol. Protocol you'll see up here, because what I found out in my work in this arena is that in terms of peer services, most people went about that as if it was a chia pet. There was beginning, but there was no end. When you acquired a peer specialist, they were your buddy for life. This won't fit the model. Protocol. There has to be a beginning and there has to be an end. And so immediately what we set about doing at Value was to develop a protocol. Interesting enough, and not strange at all, the protocol very much resembles the things that you're most familiar with, the things that clinicians are taught. Stages of change. Begins with engagement, encouragement, empowerment, education, and you have to exit. You've got to have an exit strategy. And you overlay that in 5 stages of change. And you train both clinical staff and peer staff in the same room. So that as someone put, you've all got the same guide. You're working off the same sheet of music. You all know what you're trying to accomplish and what you're trying to achieve. Motivational interviewing, secondary trauma. Let's get to the good stuff. Most of us are familiar with this. That's the clinical model, those rings in blue. The prevention. See, prevention and well-being. Well, prevention, I think most of us know, are those strategies and supports that are supposed to or designed to prevent bad things from happening, right? Prevention. Well, as we know, sometimes I don't always get my way, right? Life ain't fair, and shit happens. And so when one is affected emotionally, psychiatrically, and given a psychiatric or emotional diagnosis, we have to have some point of reentry into that individual's life. And for us, at Value, we call that recovery and peer support. So that when the individual comes out of treatment, there is something there that bridges, there's something there that captures that individual and gets them back on the track of well-being. Because after having received a diagnosis, life still goes on. Maybe this will help make it a little bit clearer. SAMHSA, a few years ago, 2006, I dare believe, released its 8 Dimensions of Wellness. A lady by the name of Peggy Swarbrick had been working on this for at least a decade prior to SAMHSA's release of it. 8 Dimensions of Wellness simply says this, that it's more than just me needing a job. It's more than me just having an occupation. There are some intellectual dynamics. There's a thing that I need to make that a rewarding experience. It says social is not just going to 12-step meetings. It's improving my smile. Let me tell you about a particular service. It was up in New York. Where did Dick go? Oh, there he is. Up in New York with Dick last week, and we're talking about, oh man, such a rich array of service offerings for the Medicaid population. Health homes. Among them was the sexiest thing that I believe happened since sliced bread. Self-directed care. Self-directed care, if you're familiar with it, says, okay, you manage your care. You are given a budget. You're giving some training in terms of the things you can spend it on, the things that you can purchase with these funds. You are given the responsibility. It begins with a plan. It begins with a goal. Someone says, yeah, I would like to smile again. What did you just say, Clarence? I said, I would like to smile again. Clinicians in the house know that, there are some medications that affect the enamel on your teeth. We've got a lot of individuals in mental health care whose enamel, that is their smile, has been taken away. And so with two self-directed care pilots, I found that almost a half of the spend that the participants were doing was on dental care. And TennCare, Medicaid, in the state of Tennessee, they pay for extraction, but they don't pay for cosmetic surgery. They don't pay for cosmetic dentistry. And so for those individuals who wanted a life, who wanted meaningful relationships, they wanted to be able to smile. Something we do so easily without having to do this. Right? So our peer specialists, that is the individuals that we hire and train as peer specialists, are individuals who understand the dynamic of life, who understand that beyond recovery is having a meaningful life, an enjoyable life. It's not good enough just that symptom remission is had. The goal should always be returning that individual to a life of hope and empowerment, aspiration, and individual and personal goals. There are many roles that peer specialists play. I mentioned some 16 different service offerings in New York. There is a job description waiting for peer specialists in all 16 of those areas. We select, we hire, we train peer specialists based on job requirements. If a person is going to be a health promoter, they need to know a little something about body mass index. They need to know a little something about nutrition. If an individual is going to be an employment specialist, They need to know a little bit of something about SSI and SSDI and how it works. Because invariably, individuals will either choose disability, a life thereof, or a life self-supporting. And there's room for the in-between. There should be ground for the planning of it, for the action of it. And oh, by the way, should there be the unfortunate event of the individual having to go back into the hospital, there should be still services available for that individual in a path, temporary or otherwise, back to support, meaningful support through disability. I mentioned the clinical team adjunct. Those are individuals who, and someone mentioned here in the room since I've been here this morning, the notion of, well, we just can't continue to do brick and mortar. In the state of Nevada, state of New Jersey, New York, Tennessee, we put teams in the field. They're home and community-based care managers and peer specialists. They're working with the same protocol, and they're working with the same understanding of where the individual is headed, based on that person's goals and aspirations, their desire for life, not ours, their desire. And it's not about giving advice. It's not about directing individuals, okay, give me a goal, and I'll tell you what you need to do. Anyone heard of the coach approach? Coaching models, coach approach? In practically every area of practice, clinical and otherwise, the coach approach is the way to go. Why? Because it puts responsibility for care in the member's hands. Our role as coach is to help them achieve the best quality of life they can, given their own aspirations and strengths, which I find amazing, that a lot of us assume we know what an individual's strengths are, but few of us have ever asked. It can be as easy as, tell me about the last time you felt really powerful, really strong, beautiful. April? You don't have to answer it. I said strong, nothing. Powerful, nothing. Beautiful. The next question we're going to be, and what did people say? You know, what did people say to you then? What did you learn about that time in your life? And is it something that you can use in this situation? Someone said, it's not science, this is an art, and indeed it is. We've got to be artful with respect to being a coach. We have to use the proper tools, and we've developed a whole lot of tools in this model so that individuals that are peer specialists and recovery care managers in the field can show an individual a wheel of life with all 8 of those dimensions on it and ask the individual to do a self-assessment, just that simple, a pictorial. Put a dot on the wheel where you feel greatest or most satisfied with regard to these 8 areas in your life. Not everybody's wheel is perfectly round. We all have challenges in various aspects of our lives, in various domains of our lives. And so do individuals with a diagnosis. And then a choice is given. So where would you like, why did you rate this area a 2 and not a 5? Now we have discovery. Huh? Now we have, well, I'm not satisfied. Well, how passionate are you about it? Very. Well, how likely will this action get you to the goal that you want. Recovering dreams, recovering lives is the most difficult part of the work that we do. But it can be the most exciting and fun if we go about it the right way. It's a strength-based approach. It's not a deficit-based approach. For many, many years, I think we've operated our systems of care on a deficit-based model. We utilize 4 basic models within our peer specialist population. We do it because we see the future. And the future is 16 million more Americans on Medicaid. And a whole boatload of veterans coming back. And it's my supposition, my hope, that no veteran should die while in treatment. No veteran should die while in treatment. There's something just not right about that. April's standing up, so I know that's my cue. So said, when she stands up, I'm supposed to sit down.
You have a couple more minutes, Clarence.
A couple more minutes? Thank you. Questions, anybody? Yes, sir.
I signed the release. You've got a powerful voice, Clarence, and not just the timbre of it, which draws me in, but the credibility and the strength with which you come from it. All of us have been through some trauma in our lives, and mine didn't hit mine until my mid-40s, and it was brutal because I'd never experienced it before. And no matter how bad it is during the day when you have peers and you have therapists and you have all the things you go through, the real boogeyman comes out late at night or very early in the morning.
Yeah.
In those hours when you're not sleeping, not eating, not breathing, not functioning,
That's right.
are the most brutal. I didn't see in the model where that plays in. This is very much a 9 to 5, I know it's not, but 9 to 5 more of an orientation. How does that play in? Because it was so critical to me.
Warm lines. I mentioned warm line. And the hours that you mentioned are, in fact, very, very critical, and we understand that. And so we stagger our staff. We stagger our warm line staff so as to have someone available telephonically for the member from 5 o'clock in the morning to 5 o'clock in the morning. It's a 24-hour clock, and life happens around the clock, and on Saturdays, Sundays, and holidays.
Less a question than a discussion. I come from I run a veterans registry. 30% of the veterans that kill themselves have bipolar disorder. Bipolar disorder is real. It's a separate category. Yeah. Mental health is really part of this whole rubric to solution. It's resiliency and strength. But I've heard a lot of conversation that sort of pushes mental health sort of off the table in the traditional view of it. But in some specific case circumstances, say substance use disorder, which this room's about, 30% of the people with substance use disorder also have a comorbid bipolar characteristic. In you looking forward to resilience and individual strength, where do you see mental health fitting in on this table?
Well, I think you're right. I think resiliency or building resiliency has to be a part of our day-to-day world. I mean, again, if you're working from a strength-based approach, building resiliency should be job number one. Should be job number one. Now, there are a number of trainings, there are a number of things that I think one can do depending upon where you are, what area you work in, that will make it easier for you to do that. That is, strengthen individuals, that is, promote resiliency individuals. Several years ago, working with the Department of Children's Services in Tennessee, we produced a video, Building Resiliency in Children. And I think that's an excellent place to start. And we utilized a lot of the material from the International Resiliency Foundation, giving individuals hope through strengthening their lived experience has real dividend. I have to plead ignorant. I don't know how we followed through with that. That is, after the video. The video was designed to train field-based staff when working with children in our system. But I think it's an important area.
Great talk, Clarence, and I echo the comments about the timbre of your voice. But I'm struck by the challenge that you must face internally within Value Options at selling peer support services as a benefit in the benefit plan. Certainly some of your clients, some of your states say, I want you to do this, and here, sort of, this has got to be part of the benefit, and then it's given. But how do you get an organization like Value, how do you make the business case for peer support services in a payer organization like Value Options?
Yeah. Well, believe it or not, my job has really been made very easy or easier because we have a CEO that believes in it. She believes in the value of peers. As a matter of fact, it was this very presentation that a group of us developed for her use in working with her board of directors. So from the top, Hayward said the value of peers is without parallel. And we plan to promote it throughout the company, not just in public sector, but in our commercial division and our federal division. It's just that important because I believe she's a futurist and she sees the direction that our community is going and knows that the current workforce that we have is not going to be sufficient. It won't sustain it. Yes, sir.
And so then is that because it's the right thing to do, and I think most of us agree it's that elements of being the right thing to do.
Right.
But also because it's cheaper labor?
Not because it's cheaper labor, because I can tell you that our peer staff is compensated quite well. We have peer staff with bachelor's degrees, master's degrees, and no degrees. And they're all compensated based on what they do and their level of positional level. We have some directors, we have a VP.
I have a comment too, Clarence. I think one of the reasons I smiled when you said beautiful was actually because I think your story is so beautiful and the way you shared it. And I think what I've noticed, not coming from a clinical background and being in community mental health, it seems like the path to recovery always involves a client seeing their own beauty. And so I guess I'd love to hear kind of from our care system what you've seen kind of helps clients get there, whether it be with a peer or if you remember a moment in your own recovery where that being able to see that, whether they describe it as strength or how that goes, what we can do that some of what we've talked about today and how that relates to value and care.
Okay, sure. And if I could finish Dick's question.
Sorry, go ahead.
Most of it is based on effectiveness because, like I said, we have claims data. An organization like Value and many of our other managed care organizations is driven by claims data, to be quite honest. And if you have a different payer model, if you have a different package, compensation package, the state says pay to play, we're going to pay for performance, then what you want are individuals who are out of the hospitals and receiving the least cost of care. What you want are individuals who will report a level of satisfaction with life that's, in the eyes of the payer, the state, the very best that it could possibly be. So it's one of not only efficiency, but effectiveness. And we know that peer services are effective. With regard to, and if I understand the question correctly, April, one more time, I'm sorry.
Yeah, just that concept of beauty and how helping patients to see that in themselves as part of recovery and how peers, I just think there's a real connect there in terms of how peers can help them along that path.
Yeah, absolutely. And I tell all the peers, every training that I do, your story is as valuable as pure gold. But only if you use it effectively. There's a need for certain aspects of your story given where the member is. Your job is to figure out where the member is. If they're pre-contemplation, if they're contemplation, if they're in the planning stage. And that part of your story that relates to where the member is the part of your story you need to share with that individual. Okay? And, oh, by the way, we have tons of individuals in our system, that is within our provider networks, that are beyond the pre-contemplation stage. They want a better life. They want certain things that from a Medicaid perspective, we can't provide. But if we think about it in terms of what's best for the individual, and if we think about it in terms of some of our reimbursement models, like shared profits, then we can reinvest some of those dollars in things like self-directed care, because then the individual who's in Tennessee receiving Medicaid services but really want to go back to North Carolina, where he came from, but his only desire is, with regard to being stuck in the system here, is he wants to graduate from his high school back in a little town I never heard of in North Carolina. Why? He had a strong, strong need to identify with the other individuals in his community. He had a strong need to identify with cousins and brothers and sisters and ex-girlfriends and practically everybody, because there was only one high school in that town. And so it became real easy for us then to contact the high school, give them the situation, find out what it was that the individual needed, and then make available to them a computer and the software at the local community mental health service center where he was receiving care to provide him that opportunity to complete his high school diploma. And after having done that, 6 months later, he's out of the center, back in North Carolina. And last I heard, he was driving a truck for Coca-Cola. He's got a wife and 2 kids.
Being part of Value Options, and Value Options being a carve-out, compared to companies like United, Aetna, other companies like that, do you see the voice of the consumer being diminished as we move toward integrated care because those companies can't value or don't value?
Yeah. On the contrary, I think having the right partner helps. If we're thinking about an integrated system of care, our partner in Nevada already employs what they call community health workers. These are individuals who are in the field working with members to educate them with regard to their benefit, be an outreach for them in terms of connecting with those services. And so the concept of peer specialists for them was one of wording, language. They get it. They understand the value of having individuals who are survivors of breast cancer helping other individuals who are experiencing that same thing. They understand it. What most people don't get, I think, is how does it work? And so to have a protocol that says this is what peer specialists are doing in the field when they're working with an individual, and have the support of a care manager and everybody's on the same sheet of music, as opposed to this, what is this? Is this some type of buddy system? No, it's not. It's a service with a beginning and an end. Anybody else?
Great. I think in the interest of time, we'll move on. Thank you so much, Clarence. That was really informative.